Good afternoon, everyone. I'm Dr. Paul Ong. I'm a cardiologist, and today I want to share with you how to treat our heart right. There are quite a lot of new technologies around in cardiology, and today's sessions, I would like to share them with you. It's a bit about myself. So let's start with a look at why we need to look after our heart. What's the disease burden as far as heart disease is concerned? I borrowed this from WHO, but rather than reading all the small print, think about it. The one that is getting all our attention at the moment is COVID. And over the last 3 years, COVID unfortunately have taken away 5.8 million deaths during that 3 years. But just to put that in perspective, during that 3 years, we probably have roughly lost 10 times the life due to cardiovascular disease. So it's a major problem, and it's happening in Singapore as well. We have benefited from some of the best healthcare system anywhere in the world, but still you can see roughly about 29% of the population are still passing away because of cardiovascular disease. Chest pain, okay, that's a common complaint that my patients come to me. Chest pain on exercise while they're exercising. So why chest pain, exercise, and heart disease? Coronary artery disease, what actually is happening? So let's have a look at this. This is coronary artery disease. You can see the heart, you can see the coronary artery, and when the coronary artery has got some narrowing, blood flow is sluggish. Now, if we are resting and not doing much, despite this sluggish blood flow, it's okay. But when cholesterol builds up in the arteries and narrowing down, and we start to exercise, the heart needs to go faster, stronger, and ask for more blood and oxygen. These arteries can't keep up, and this is when we start developing symptoms. And so when we don't feel well, we stop, chest pain disappears. So coronary artery disease a lot of time presents with chest pain on exertion or chest discomfort on exertion. If we look at the heart arteries, you can see that initially they are actually pretty normal, nice clean arteries. But when cholesterol starts to build up, it gets to a stage that you now have cholesterol plaque inside. So the arteries got narrowed. Now these cholesterol plaques are quite frail and they can break, they can rupture. And when that happens, clot can suddenly form and suddenly the arteries get totally blocked off. And in this case, we may be looking at nasty things like heart attack. One way to look at coronary arteries is by a non-invasive technique called CT coronary angiogram. Now I put up two pictures. The one on the left is a nice normal coronary angiogram, CT coronary angiogram. These are non-invasive tests, just doing it on the computer X-ray screener. You can see the artery is nice and clean. You can follow up all the way to the end. In the blocked arteries, you notice that something is not right here where I'm highlighting. And indeed, you can see in the enlarged view how the blocked artery looks like. It is important for us, and now if you don't walk away with anything else, this is an important slide. Recognize what the symptoms of heart attack look like. Okay, people typically complain of a heaviness in the chest. The discomfort can spread up the jaw, down the shoulders as well. A lot of time, patient will be sweating profusely, and they will feel quite breathless. But the most important, they know something is wrong. There is a general sense of doom happening. So I show you the picture of the plaque. This is what happened when the plaque rupture. It's almost like a volcano rupture. Part of the plaque gets disturbed and disrupted, clot form. So suddenly from an artery which is a little bit narrowed, blood clot formed, and you can see as the clot gets bigger and bigger, it will eventually completely block off the artery. And this is the part when the blood supply and oxygen to the heart muscle get blocked off, the heart muscles start to suffer and die off. And this is what we call heart attack. And you can see why in a lot of heart patients, they take blood thinner, such as aspirin. And this is exactly the reason. They try to prevent the blood clot. So the best treatment for heart disease, for coronary artery disease, especially in heart attack setting, is using balloon and stent. Let me play this video and show you what's happening. So the doctors here will put usually a tube either through the wrist or the groin. Under X-ray screening, we'll screen this tube up to the heart. And once this tube is near the heart under X-ray screening, it will engage our coronary arteries, our heart arteries, where we can actually inject some dye in to look at the heart. And this is what we call an invasive coronary angiography, different from CT angiogram. This is a tube actually inside our body. And you can see in this cartoon, the artery has got a blockage. This is where the cholesterol plaque is. I would then put a wire through this blockage, and through it, I will put a balloon in. And you can see when the balloon is inflated, you can push away those cholesterol plaques to the side. Now the arteries become opened. And blood flow can be restored after the ballooning. But that's usually only part of it. The second part will involve putting a metal stent. And this is what a metal stent looks like. Think of it a little bit like a chicken wire being rolled up like a tube. Okay, this is then crimped on a balloon, mounted on a balloon, and same thing, this will be inserted into the coronary arteries. These stents are metallic stents, typically made of stainless steel or cobalt chromium. So you can see that balloon is inflated and the stent is now embedded inside the coronary arteries. These are permanent implants, okay? And once they put in, they stay in the arteries long term. And with the stent, the artery is now opened and blood flow can be re-established. I'll give you an example of a patient on angiogram, what it looks like. This patient came in with a heart attack. You can see that the artery here is blocked off. And once the artery is unblocked, you can follow this artery up all the way down. So this missing artery has now reappeared and the patient been treated successfully for his heart attack. Now, can we do better? Are there new technologies to make the whole procedure of angioplasty better and more precise? Yes, these days we can employ a robotic assisted angioplasty. I'll give you a picture, idea what this looks like. We actually the first country in Southeast Asia to have this technology in Singapore. This is a 55-year-old lady with the usual three highs: high blood sugar, high cholesterol, and high blood pressure. So you can see that this is her coronary artery. You notice that in the middle here, there was a narrowing of the artery. I estimate it to be roughly about 90% blocked. My fellow inside the lab, mounting the balloon and stent onto the robotic arm. This does not require any skill set. Anyone can do that. Anyone who is medically trained or nursing trained can put this device in. Okay, once he's done that, I will be sitting in the control room facing a big monitor, and you can see that these are like the old Atari joysticks. You can manipulate the wire that you saw early on, the balloon that you saw early on, or the stand that you saw early on. And I can actually move the wire down, push the balloon down, and position things exactly where I want to be. And you can see the distance between myself and the screen is very close. So there is no issue of whether my eyesight is good or bad. You know, with a huge screen right in front of me, I can see very clearly. This, using the robotic technique, I can move the balloon and stand millimeter at a time. And that's really important. I'll show you why it's so important to be precise. Okay, so now the balloon is inflated, which is what it looks like, this sausage shadow. The balloon is inflated and the artery is being stretched open. Okay, and you can see using the robotic technique, the artery, this particular artery is opened up very nicely with a stent being implanted. So what else can the robotic do? Of course, in the COVID time, we talk a lot about working from home, remote delivery of service, contactless tracing, robotics and drones. This robotic PCI also can be used in this kind of setting. I'll give you an example is what's happening in America. A year ago when in New York City, there were lots of cases. We can only leave one nurse inside the control room with the patient. And you can see here, they drew a big red circle around the patient. So these are the 1 meter partition. Okay, so the nurse will walk near the patient, put the balloon and stent in, and then walk away. The doctors sit in a different room, and this can be in even a different hospital. So imagine patient could be in NCID in Singapore, and I can be operating somewhere in Changi Hospital. So we can actually keep that distance and still deliver the service to this patient without putting other healthcare workers at risk. So does balloon angioplasty always have to end up with a stent? the next topic of discussion. Okay, you saw how nice the artery can look after a stent being put in, but do we really always need a stent after the angioplasty? Well, I think a stent is useful because sometimes arteries are elastic. If you just balloon it and you take away the balloon, it can recoil, the narrowing can come back. And during the ballooning, sometimes the artery gets damaged a little bit, the inner lining can be a little bit torn, so the stent helps to tack everything back up and make it nice. The artery eventually looks really pretty on angiogram. Angioplasty, plastic surgery of the artery. But it's not a natural product to be left inside the artery. I understand. The artery is caged. It doesn't pulse anymore, meaning the artery doesn't expand and contract anymore once the stent is put in. With metal inside, you also need to take blood thinner for a longer period of time. And I will come to that shortly. The stents sometimes need to be placed in a very awkward position and make it technically quite challenging. Or a lot of patients come to me and ask this question: I just don't want anything permanently left inside my heart. Can you do it without it? I've written this together with some of my colleagues on a new device called drug-coated balloons. It's actually not that new. It's been around for more than 10 years. What it does is we only use a balloon. We don't use stents, but this balloon is special. It's got medication on its surface. What it does is think about like painting the inside of the artery with some medication which are pro-healing, so that once you balloon it, it will heal up nicer. No scar tissue inside. We know that sometimes we cut ourselves, the scar can have keloid. Imagine if you do that inside the artery and you heal with a keloid scar, the artery gets blocked up again. But with medication, it will control the healing so that the final result can be really, really good. I'll give you some example here. So this is an example of what the artery will look like. Okay, when the balloon inflates, the drugs are now in contact with those cholesterol plaque, with the artery wall, and the drug will seep into the arteries. Okay, this contact needs to take place about 45 to 60 seconds and the balloon will be removed. The drug will stay inside the artery and continue to act on the artery for the next few days to control the healing process. Okay, don't take my word for it. Let's see some example. Okay, I'll share with you a 59-year-old gentleman who came in with a small heart attack. You can see the artery is narrowed. I pointed out on the arrow. You can probably see there's about a very tight narrowing in the artery. Can you see that? Now this part is awkward because if you can see that the artery narrowing is at a trifurcation point. It's almost like your road. If you drive, this is a three-way junction. If you put a stent in, sometimes it will block off the other two normal arteries. This is tricky. Think of it like the road, as I said. This is the T-junction. Okay, now there's some road work. Okay, so we need to fix this, but we don't want to affect the other road. So we were thought, we need to clear this blockage. We put a stent in. Okay, we put a stent exactly where the blockage is, flush, so we don't disturb the other road, and now we clear the blockage. That's fantastic, but we're talking about millimeter accuracy. If you get it a little bit wrong, this is what happened. The stent gone too far. Now it's blocking off the other healthy artery. Or the stent didn't go far enough. You didn't clear the blockage. And these stents, remember, are permanent implants. So you can't have another go. You can't take it out and put it in again. So you see why this is difficult and why robotic is helpful, because you can place it very precisely. But the other way to deal with it, of course, is think about using these drug-coated balloons. This is the example I showed you early on. If you don't want to stand across it and therefore risk affecting the other arteries, what can you do? Here, we're ballooning the vessel with a normal balloon. The artery seems to have opened up a little bit better, not as bad as before, a little bit improvement. We now use a special balloon. This one got blades on it. Okay, they actually cut and actually open up the blockage even better with this kind of cutting balloon. Now you look at the artery, it looks really nice and tidy now. And at this point, I put in this special drug-coated balloons, position it where I want, inflate it, and then take it out after 60 seconds. So you can see that the artery looks pretty good. Almost back to normal. Almost back to normal. Not quite, but looks much, much better than how we started. 7 months later, this patient came back for a repeat angiogram just to check. And you can see at 7 months, the artery looks even better. The healing had taken place, the artery looks wide open, no stents required. Can you see that? What was like before, and at 7 months, how it looks now. Much, much better. Another example is a 39, much younger, a 39-year-old Chinese with previous history of stroke, high blood pressure, and smoker. Again, you can see a narrowing at the branching point. This again will be awkward to use balloon and stent, to use stent to do it, because again, it might block off the other arteries. So here, we use drug-coated balloons once again. And we can keep the blood thinning drugs quite short. So people who are high bleeding risk cannot tolerate long-term blood thinning. This worked really well. And almost 1.5 years later, just over 1.5 years later, we relook at the artery, and you can see the results still remain very good. And that's stood the test of time. Before the narrowing, and 1.5 years later, the result remained very good. So you can actually perform angioplasty with very good outcome with no stent in a selected group of patients. The final topic I want to share with you, and I recently was in the news a little bit, is about doing what we call protected PCI. We now have patients that come to us who are too frail or the heart is too weak to go through open heart surgery. They cannot have normal angioplasty, they cannot have heart bypass surgery because the patient themselves have too many medical problems. They're either too old, too frail, or already have a lot of coexisting medical problems. So I will share with you this case, which is one of the earliest cases that are done in Singapore. 61-year-old gentleman who is dialysis dependent. All his arteries are blocked and his heart is really, really weak. A healthy heart usually have a function of 60% at rest. This one down to 20-25%. He's already seen the surgeon for open heart surgery. Surgeon turned him down. Patient also don't want it. So what are we going to do? How can we perform angioplasty in someone who is so sick? I show you the picture of what his heart looks like on ultrasound scan. Just take my word for it. This heart is not contracting well at all. And the danger, of course, is as soon as you put balloon inside the arteries, the heart might just stop and the patient may be in grave danger. This is like doing your aerial acrobat. Okay, anything gone wrong, any slip, we're in trouble. So when we're doing this type of angioplasty, what we need is a safety net, something to back up. In case something gone wrong, the heart can still be sustained. This is where I want to share with you what we call the impeller heart pump. This is one of the world's smallest heart pump. It can actually insert it under local anesthetics via a keyhole procedure. And what this pump does, it actually keeps the heart going or keep the circulation running, even if the heart really struggle or come to a complete stop. These devices are fantastic. So this is an example of the patient that I was talking about. You can see these arteries are awful, or take my word, the blood vessels are really bad. And we require a lot of effort to revascularize. We require a lot of effort to balloon and stent this artery. And during this time, the heart may actually risk stopping. Okay, we need to do a lot of work to open up this artery. And this is how we insert this heart pump. You can see under X-ray screening, the heart pump is going up from the leg up, the leg artery, and we're pushing it up all the way up. And you can see it going now, tracking down towards and enter the heart. And once it's entered the heart, it will sit there and continue to pump and support the heart. And this is what the artery looks like after we completed the procedure in 2.5 hours with 3 coronary stents being put in. The results is really good. And this is what it looks like after and before. The procedure went well and the patient was discharged 2 days later. Some of these technologies are currently only available in Singapore and not available in the rest of Southeast Asia. Our early experience has been published and shared with the Taiwanese colleagues. Some of my take-home messages, therefore, treat your heart right, because we only have one. Recognize the symptoms of a heart attack and I shared that with you earlier. I think coronary angioplasty still provides the best treatment for heart attack patients. In a selected group of people, the use of drug-coated balloons only angioplasty without implanting stents is possible, and actually in some cases may be preferred choice. I discussed about how we can use robotic to help and assist in angioplasty in terms of precision angioplasty. And in some high-risk patients who are very frail and have multiple comorbidity, the use of impeller heart pump does provide a safety net to allow us to perform angioplasty successfully. Thank you for sharing this session with me. And if you require any more information, please put it in the chat group. And also you can scan the QR code and I can come back to you. Thank you.